Yeah. Hi, everyone. Welcome to podcast by Bear for Health. And today we'll be diving into the health topic, which is much more common than you think. We're talking about deep venous thrombosis, pulmonary embolism, together called venous thromboembolism, so VTE. And so it used to be very common in the Western world, and everyone used to say that in India, DVT doesn't happen. That was a myth. And we actually did a lot of studies on DVT prevalence in India and especially in Delhi. So over half of all the patients in our hospital were evaluated and were found to have a much higher risk of deep vein thrombosis. So we're going to talk about this with Dr. Nikhil Sharma. He's a senior consultant vascular surgeon at Sir Ganga Ram Hospital. I'm Dr. Ajay Yadav. I'm also senior consultant at Sir Ganga Ram Hospital, New Delhi. So we're going to be talking about venous thromboembolism today, DVT, pulmonary embolism, and Nikhil, you want to add something before we?
Yes, sir. I think everyone talks about blood clots, and the only disease which comes to mind for the layman is either heart attack or maybe stroke. But this disease, which is exclusively caused by only blood clots, which is DVT, or its more serious version, which is the pulmonary embolism, is not you know much dealt with in the public domain, and the layman is not very aware of what kind of serious disease this is, because this, as a healthcare professional, we come to know once we are counseling the patients. Now if you
Absolutely.
have a patient who has DVT and you counsel them that they might develop pulmonary embolism during the treatment or without treatment, and that can be actually fatal, then they're really shocked, because something as benign as a leg swelling can actually take your life. And sir, we've seen cases of this happening under our own eyes, that patients develop massive pulmonary embolism, and by the time they come to us, it's already very late. We cannot do anything about it. So I think
Absolutely.
the key here is to educate the audience that, this is again a very, very serious condition, and it is not only a simple leg swelling, it is much more sinister than that.
Absolutely. So something which is can be as benign as a mild swelling because of
Right,
half vein thrombosis can eventually progress to fatal pulmonary embolism. I think
right, absolutely.
this is what our podcast today will be focusing on. So, going on to the first question, I think, Nikhil, would you want to tell us more about who are at risk of developing DVT or which are the more common causes of DVT? So,
Sir, we normally talk about the causes of DVT in terms of Workhorse triad.
yes,
Uh, there are three things, one is stasis of the blood in the veins, which can be due to immobility. One of the reasons is any orthopedic injury, which forces the patient to be on bed rest for a long time.
sure.
And many DVT patients who are presenting to us much later in their disease, often when they're probed properly, they give a history of some kind of orthopedic injury where they were on bed rest and they developed massive swelling in their leg, which might or might not have been taken seriously at that time, because it might have been get camouflaged with the symptoms of the orthopedic injury. So they
Mm.
don't, even seek the evaluation of that kind of leg swelling. So one is obviously immobility, which can be due to injury, or it can be due to ICU stay, or then prolonged immobility maybe on long haul flights also, as we are seeing nowadays.
Economic.
Correct, sir. Economy class syndrome. And again, pregnancy, I would say, in certain predisposed patients becomes a high risk condition, especially if there is any thrombophilia attached to it. Then one important thing, sir, which we are seeing nowadays, which has to be discussed further, I think, with you, is going to be malignancy or cancer, which is a very, very major cause of DVT in today's time when we are seeing such rapid increase in incidence of cancer. And I think, sir, you would agree with me that some patients now, when they come to us with DVT, and that is the first time they get a diagnosis of cancer from us as
Us.
as vascular surgeons, because we, being vascular surgeons, are not directly involved in cancer treatment, but because of the association of DVT being very strong with cancer, sometimes the first diagnosis of cancer is made by us.
Absolutely. I think if we classify causes of DVT, I think it will probably go into two major classification. One
Right,
is provoked and other is unprovoked.
right,
So the unprovoked
absolutely,
is the one where more of genetic factors are there or hypercoagulability. It could be because of protein C deficiency, protein S, or in especially as he was mentioning in
factor,
pregnant ladies, it could be lupus anticoagulant or antiphospholipid antibodies, which are
right,
making the patient prone for clotting. So these are usually a younger group of patients. They will be fitter, but suddenly develop deep vein thrombosis without any major, I would say, provocation. And these are the unprovoked ones. But the provoked ones are the ones, as you rightly said, are probably after a bout of bed rest or complete immobility, which is common after stroke, after orthopedic surgeries, or orthopedic injuries, over trauma, cardiac failure.
right,
Uh, I think one of the provoked causes, to be some extent, is cancer and the chemotherapic agents. Any of the
correct,
major pelvic surgeries or
right,
pelvic malignancy surgeries, knee transplants, hip transplants. I think all these factors will together be clubbed together as the common causes of deep vein thrombosis.
correct,
And I think cancer here is something which was not thought about to be so thrombogenic.
correct,
But I think the data in last 2 decades has made it clear that cancer per se is highly thrombogenic, especially pancreatic cancer,
right,
uh, is stomach cancer, and they are the ones who are which have been found to be highly thrombogenic and cause massive thrombosis. It is not just the cancer per se, but also the chemotherapy which goes along with it. So
right.
certain medicines, the inflammation, also a part of being the virtuous triad where the chemotherapeutic agent causing inflammation of the veins which predispose the patient for deep vein thrombosis.
So incidentally, sir, I just had a patient, sir, who came to casualty at night with right lower limb swelling. This is 1 month ago, and he was just on Clexane or some anticoagulant agent, which was being given at an outside hospital. We did a Doppler. We found that right iliofemoral DVT was there. So he was having some breathing issues. I thought let's get a CT pulmonary angio done. And along with that, I thought let's get a CT of the abdomen as well, just to look at the IVC. What we found that on the patient had acute DVT on his left common iliac as well on the opposite limb, which was totally asymptomatic. Along with that, the clot was extending up to the renal vein. Along with that, he had a very big lesion in his right lobe of the liver.
Oh,
So, so this is how cancer can lead us to a diagnosis. Sorry, DVT can lead to a diagnosis of cancer, like you were saying.
absolutely. So what would be the common signs and symptoms of DVT? So how do you know the patient is suffering from DVT? So what are the general for general public or a young doctor coming out of MBBS would want to see?
So I think, sir, the most common thing which the patient presents to us is gross leg swelling, and it is pretty massive. It is insidious in onset. Someone might be sleeping on one night, and suddenly he wakes up in the morning with a grossly swollen leg, and the swelling actually increases to a point that they have to seek some kind of treatment for that. There can be calf tenderness, especially on the flexion and extension of the foot. And, if the DVT is really massive, then we find something like phlegmasia. We have patients coming to us with totally blue, cyanotic limbs, where there is total, every single vein in their limb has been thrombosed, and that is called phlegmasia cerulea. And one or two cases, sir, I have seen, maybe more even, I think, where they actually had to lose their limbs because of this serious
Yeah.
condition.
So
The
this,
entire limb had to be amputated because of this.
because
So
in
that
very
is a
severe cases of DVT, the patient is prone to get venous gangrene as well.
yes, sir, yes.
And of course, the pain is very excruciating usually.
Mm,
And there's a red swollen leg is a classic what is described for deep vein thrombosis.
correct,
And whenever the clot sort of travels into the pulmonary circulation, the patient gets
correct,
chest pain,
right.
tachypnea, tachycardia, and of course, severe breathlessness. I think breathlessness is
Yeah,
the number one cause, number one symptom, and followed by tachypnea, where is breathless severely. So I know DVT in legs may not cause any symptoms, and as you were describing, the patient was asymptomatic on that side. But what are the consequences of ignoring the symptoms of DVT? So what is the worst that can happen, and how do
sir.
we, what should we do
Yeah.
next?
So if you're ignoring the symptoms of DVT, like I said, it can go on to much severe forms, like we just discussed, cerulea. More uh, sinister or more dangerous would be if you ignore DVT and it really embolizes, just travels up to the pulmonary circulation, where it causes the more severe form of the VT, which is pulmonary embolism. And what that is something which immediately can cause mortality of the patients. Would you like to add something upon that, sir? This
Absolutely. So I think starting with a leg swelling to the venous gangrene that you're talking about, which is basically in the legs, which is a neglected severe form of deep vein thrombosis. But when it goes into the lungs, it can range from a subsegmental thrombosis, pulmonary thrombosis, where you might have some pleural rub or a severe pleuritic pain, some chest discomfort, and cough, and even a bit more severe cases, a bit of hemoptysis. But
right,
I think it's the major, when you get central venous thrombosis, which is basically the right and the left main pulmonary
main
artery,
trunks, right,
the
right,
main trunks, when they get thrombosed, the patient gets severely breathless, there's severe hypotension, and the
correct.
patient can collapse. Uh, there have been reports, and we have actually seen
We've
one
seen, sir. Yes,
patient
we've seen.
where they get out of the airport and probably the economy class syndrome, they had DVT, and the clot traveled to the lungs as soon as they cleared immigration. And just while walking, he collapsed and died. I think
Right,
this is something which is the most sinister form of uh,
right,
DVT complication. So how
right.
do you diagnose
But
this at this
right.
level? So you're
So,
suspecting DVT in a patient. So how do we diagnose this?
the diagnosis, I think, apart from clinical signs and symptoms which we've just discussed, the diagnosis, earlier was, as I would say, was based upon the well scoring and all those criterias, where you get a D dimer done and then you decide whether the patient requires a Doppler ultrasound or not. I think now the world, with the moving, changing times, we have more accessibility to ultrasound or Doppler and, POCUS, which is point of care ultrasound, where a simple compression ultrasound, not even a Doppler, but just a compression ultrasound would actually, be instrumental in either ruling in or ruling out DVT.
Absolutely. I think the
Yes,
one of the first thing as a surgeon we were taught, especially as a vascular surgeon, was doing your own Dopplers. And I think doing a compression Doppler, which is the easiest thing to do,
correct,
you compress on the femoral veins, the common femoral, the superficial femoral, and the popliteal vein, and see a bit of tibial veins and calf veins, where you can demonstrate that the veins are patent. I think it reasonably rules out most of the cases.
correct. I agree.
Of course, IVC DVT or the proximal iliac DVT will require
Can
probably
be.
CT scan. So, an ultrasound, duplex ultrasound is what is recommended.
Right, right.
If you're suspecting that there's a pulmonary embolism, a CT pulmonary angiography is what is needed.
Yes,
2D echo might also at some times give you an indication how bad the pulmonary embolism is. If there's massive dilatation of the RA or the RV with pulmonary artery, severe pulmonary artery hypertension, it's an indirect indicator that the patient might have deep vein thrombosis. There are other tests like CT scan of the abdomen or a ventilation perfusion scans, which may be done, which may not be required. But I think with easy availability of CT scan everywhere and very easy availability of ultrasounds, I think these are the two main things we should be able to get in most of the centers. So what are the
Right.
treatment options as of today? So a patient comes to, I'll give you three scenarios, and I think we'll discuss all three quickly. We have the first case is where we have a calf vein thrombosis. Patient is having bit of pain but has calf vein thrombosis. So probably start the patient on anticoagulation.
Yes, sir. I think anticoagulation is the answer when there is limited distal DVT and when the patient is relatively stable, they can adhere to medications. I think now the treatment has shifted more towards outpatient therapy, I think so. And
Absolutely.
in this also the choice of the agent which you can use. Now I think about your input, sir. I think we are now confidently prescribing DOACs or the oral anticoagulation agents now, right
Yeah,
from the word go, because earlier we used to rely on LMWH, and then used to switch over to the DOACs agents. But I think now we can confidently from the day one itself we can start on the DOACs.
absolutely. I think there are two ways we can treat this, and one is, of course, the traditional way, which was low molecular heparin followed by
Correct.
warfarin or acetron. But I
Right.
think in last 12 years or 13 years
Yes.
or so in India, we have practically gone on to low molecular heparin has as a second therapy, but first is probably in at least minor cases,
Yes.
like half vein thrombosis, we can directly go on to using a DOAC in a higher dose, the recommended higher
Yes.
dose. If it's rivaroxaban, it is 15 milligram twice a day for
Twice.
3 weeks. If it is apixaban, then it's probably 10 milligram twice a day for at least a week, 10 days. But if
Right.
it's dabigatran, then it has to be overlapped by low molecular heparin in the first week before
Yes.
you switch over to dabigatran.
Correct.
But I think
Correct.
starting all this is basics. Uh,
Right.
and if now, second scenario is where the patient has iliofemoral DVT but no pulmonary embolism. So, uh,
So, sir,
symptomatic for the leg but not for the chest.
at Gangaram Hospital, sir, we have been dealing with this kind of patients for a long time. And if the patient is symptomatic, he has iliofemoral DVT, they're reasonably young, they have a good life expectancy. And these kind of patients, sir, I think we are offering interventional treatment to them in the form of early thrombus removal strategies. Earlier, we were going with the mechanical thrombectomy. Now we have computer-assisted thrombosection now, where
Absolutely.
we can, give them complete clot removal in one session without having to rely on thrombolytic agent infusions like we used to do earlier. So, what are your experiences with this thing, sir?
Absolutely.
This new form of therapy which we are
So
giving?
if it's a young patient, especially with who has an active lifestyle and has a low chance of bleeding, so I think the
Yes,
risk of bleeding
that's
is
more
to be
important.
looked into here.
Correct, sir.
Patient has a low risk of bleeding but has an active lifestyle where he would not want a chance of post-thrombotic syndrome. And I think
Yes,
this is a group of patients where we would offer a early thrombectomy. I would say
yes, sir.
now it's a completely endovascular catheter-based thrombectomy
Correct.
procedure. And but this is of course followed by a full course of anticoagulation,
Exactly.
3 months, 6 months, or whatever the duration
Yes,
it has to be. But I think for young patients or patients who have a more active lifestyle, I think there is a good indication to provide an early mechanical thrombectomy in these patients.
correct.
But to patients with massive pulmonary embolism, non-life threatening, I think a IV uh, bolus thrombolytic agent is what is
Yes,
systemic thrombolysis is recommended. But if it is a patient with severe hypotension or patient who's sinking and or has had a massive pulmonary embolism, I think the same mechanical thromboectomy of the pulmonary arteries has been shown to be life-saving in most of the cases.
right.
So, Nikhil, what would be the duration of such treatment? So, how long would you want to give them?
Sir, if it is something which is provoked DVT, at least a treatment period of 3 months, I would say, at the very minimum. Nothing short of 3 months, and ideally, I would normally extend it in my own practice up to at least 6 months is what I do, because anything short of that, we are dealing, looking at recurrence of DVT, which is very traumatic for us as treating physicians and for the patient. So at
Absolutely.
least that much is the very bare minimum in patients who are having thrombogenic risk factors, and as you rightly mentioned, who are not at risk of increased bleeding. I would really continue this to up to a period of 1 2 years maybe, because that risk factor remains with them
Absolutely.
essentially. It doesn't go away with time as such. So
So, as you
yeah.
rightly said, the differences between provoked and unprovoked.
And just one small incident, sir. I remember a patient had come to me. He had DVT. He was given rivaroxaban. His dentist had to do a procedure. He stopped the rivaroxaban. He came with massive DVT. Just for 3 days, he had stopped the rivaroxaban. A very recent case, which I just wanted to share with you.
Absolutely. So, the patients who have unprovoked DVT, so probably have high genetic tendency
Correct.
to clot. Now, these are the group of patients which might even require lifelong anticoagulation.
Exactly. Exactly.
Obviously, they need to be
100% I agree with that.
so they will obviously need to be tested every 3 months, 6 months when the risk factors go away. But so the general dictum is all anticoagulation to be given for minimum of 3 months. After that, reassess. If it's a non uh, provoked DVT, then probably longer, definitely longer, I would put it. But if it is provoked and that risk factors has disappeared, like it was a surgery, post hernia surgery, bed rest, and which caused this, and it has disappeared, and the veins have good recanalization, you can probably stop at 3 months. But if you find that the risk factor is continuing, something like stroke, which was provoked by stroke, but because the patient is still on bed
Right.
bed rest or immobility, the anticoagulation needs to go on till the provoking factor is removed. You agree with me,
Correct,
Nikhil?
correct, sir. 100%.
And for cancer, I think it is still the patient is cured of cancer or uh, no longer requires because he
Right.
is cured and is no longer on chemotherapeutic agents.
And with the the newer, not new, I think the trials which have mentioned the extended anticoagulation, like the Einstein extension trial. Now we have lower doses of these agents available to us for the extended treatment period, which can prevent recurrences, relapse of DVT. So I
Absolutely.
think
I think
yes, we have
important
evidence also.
is
Yes,
that it should have a anticoagulant effect, but at the
correct,
same time not increase the risk of bleeding.
correct.
I think at all these scenarios, one has to equally look at what are the risk of bleeding. A patient with a high risk
Yes,
of bleeding, a patient who has a gastric ulcer or has piles, probably would
fine.
require a shorter treatment
Yes,
versus a patient who is fit and can tolerate all these anticoagulants well, we probably give it for longer. So
correct.
one or two more questions before we wrap up. One of them is, what are the do's and don'ts for a DVT patient? So what do we tell a patient comes to you in your OPD with DVT? So what do you tell him to do and what not to do?
On the initial, sir, when there's a first consultation, for acute DVT, I would, really advise, as we've discussed, according to the scenarios, the appropriate treatment for that patient, whether
Hmm.
it is, outpatient-based therapy or the patient requires admission as well as mechanical thrombectomy. So the appropriate treatment. Second, which we very importantly tell them is not to, mobilize a lot, because then the risk of the clot traveling to the lung becomes more. Or if they're doing some kind of massage in their legs or something, then the risk of embolism increases pretty substantially with that.
Absolutely. Because in Indian setup, swelling means massage.
Yes, correct, sir.
So I think this is one thing which we have to very carefully tell all your patients that please do not massage, at least not vigorously.
Right.
Two, if it is just calf vein thrombosis, then early mobilization can be allowed.
Yes,
But
yes.
it's iliofemoral, or then I think the need to, I would say, not strict bed rest, but preferred bed rest, till
Right,
the swelling comes down, because the swelling is the one which makes them very uncomfortable. Uh,
right.
so in modern scenario and the sedentary lifestyle that a lot of people today have, so what are the measures we should take to prevent the risk of developing DVT? So what are the preventive things you would advise? I think
Sir,
economy class syndrome is one.
yes.
So that is when a heavy patient sits on a very long flight, any flight more than 4 hours, economy side where he doesn't walk, has had some alcohol, is dehydrated. These are the group of patients who would have a much higher chance of developing deep vein thrombosis during the flight and afterwards. So what are the measures would you suggest?
Sir, there are DVT stockings now which provide you a, constant compressive pressure on the legs. Also, if you're traveling by, on long haul flights, especially like India to US, where the 16, 17-hour flight is there. So I would always recommend the patient, the people who are at risk, or even the general public, to just kind of walk around the flight as much as possible to prevent stasis of the blood when they're sitting at the same place. Also, now with a lot of people who are working with their laptop sitting at the same place for 10, 12 hours at a stretch, the people who are working on office or work from home kind of a scenario where they're sitting on desk jobs and not moving around. That is again a big thing which has to be prevented by moving around as much as possible, I think.
Agree.
And what
Absolutely.
about, sir, obesity? With the advent of so many drugs now to treat obesity, I think what would you suggest? Someone who's obese and struggling with, risk of DVT.
Absolutely. I think obesity, pregnancy,
Right,
sedentary lifestyle, I think these are very common factors. Of course, genetic factors. If you have a family history of deep vein thrombosis, a strong family history, then I think one you should try and get in touch with a healthcare provider and try and get some investigations done, which you
mm,
can rule out a genetic cause. But I think one more thing is with a lot of surgeries that patients undergo, especially knee transplants or hip transplant, I think the need for prolonged anticoagulation is these group of patients. So the recommendation now are for at least 4 weeks of anticoagulation, preventive anticoagulation after any
right.
of the knee or the hip transplants. Even if you are in bed, admitted in hospital, I think after a certain period, you should need to discuss with your physician whether we should continue with some anticoagulation to prevent in-hospital thrombosis. I think a great discussion with you, Dr. Nikhil.
Thank you,
And
sir.
and I think I'd like to again emphasize for all our viewers that there is importance in staying fit, the importance of staying active. You recognize the symptoms of deep vein thrombosis early, like swelling, pain, of pulmonary embolism. If you suspect anything, seek timely medical attention. Try and get hold of a vascular surgeon who can get a quick Doppler for you, some blood tests like D-dimer, so which can actually rule out deep vein thrombosis. And of course, follow all the prescribed treatments according to age, according to the level of deep vein thrombosis you have. Nikhil, would you want to add something?
I think, sir, you've made all the relevant points there. And just one point I would like to make is DVT is not a disease which can be ignored. It can lead to very serious complications, as we've discussed. And the treatment has to be timely and it has to be tailored according to the patient so that we can prevent the complications arising from a seemingly benign disease like DVT, which I think the people think like that.
Absolutely, 100% agree with you. If you
So,
find the podcast valuable, share it with others and let's spread awareness about DVT and pulmonary embolism. Stay safe and take care. Thank you very much.
thank you, sir. Thank you.
Thank you.